us for this webinar today entitled BPH Surgical Management, What's Become the Gold Standard. Today we are very lucky to have with us Professor Jean-Nicolas Cornu from France, who will speak in details about the BPH surgical management. Also, I want to apologize because some of you know that Mr. Ebbing will be present with us, but Mr. Ebbing has another commitment and couldn't join us today. Professor Jean-Nicolas Cornu is a world-renowned expert in urology, specializing in urourology, incontinence, and lower urinary tract symptoms. Thus, he is particularly active in the European Association of Urology, where he served as a member of the Scientific Committee Office and as an associate editor for European Urology. Professor Cornu's expertise has been instrumental in the development of new therapeutic approaches for urological disorders. He has co-authored over 250 scientific papers, and his work has led to the advancement of disease management and new concepts in lots. As chairman of the Male Rights Guidelines panel, Professor Cornu is at the forefront of developing guidelines for the European Association of Urology. And Professor Cornu has prepared for us a great presentation today. I hope you will enjoy it. First of all, our disclaimer. You should always keep in mind that these materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every patient or case. You will have an active role, as usual, in deciding which technique to adopt for your patients. Also, a quick reminder of our platform, Educare. It's a platform where you can find a lot of resources, a lot of educational content like slide decks, videos, courses, mainly about urology in general, but also about BPH. So we really encourage you to log in to Educare and create your account, where you can see as well the upcoming events regarding urology from Boston Scientific. So back to today's agenda. First of all, we'll talk about BPH history. I will let maybe Jean-Nicolas, you can share your screen now, where we will see the detailed agenda. I will also share with you a poll just to know more about your practice and also what would interest you in the future regarding also our events.
Okay, Joseph, do you see my screen?
Here we can see your screen.
Okay, perfect. Thank you very much for welcoming me today for this very exciting topic, lots through the ages. So we will start with a kind of historical overview of LUTS BPH surgical management. Then we will put in question why TURP should be the good solution for everyone. Then come on the lasers introduction, the technology and the techniques. How did it change our armamentarium? And then discuss the minimally invasive options, because these are at the other side of the spectrum. You will see other solutions, but the test of time is essential for those options to be discussed. Then I will propose a conclusion before discussing with you all your main questions that may have come through the chat during the presentation. So let's start with an historical overview. The male LUTS history started at the end of the last century. At this point, transurethral resection of the prostate, TURP, was widespread and very popular. It was used for everyone. And it was taught in all residencies and training programs. It was the main procedure coded by urologists in the United States. close to 1 out of 4 men in the USA was estimated to go TURP in his life. And at some point, the scientists and urologists came with guidelines stating, well, we are doing TURP to everybody. What is indeed the good indication for TURP? And some people suggested that the indication was age over 60 and a positive wallet biopsy, meaning you have reimbursement. So this was a true citation. It's not kidding. But aside this, there was a first tentative rationale for guidelines, and this is the first book that was issued in the USA, Clinical Practice Guidelines about BPH. Of course, this very first book, copied here, was very basic, and you will see that the initial evaluation was mainly clinical with DRE. PSA was considered optional at this stage, and the symptoms were evaluated roughly. The IPSS was introduced at this moment, and you see the options in case that there was like a likely obstruction or there was a complication were only TUIP, TURP, or open surgery. Balloon dilatation was proposed at this time, is not proposed anymore. And aside, we had medical therapy and watchful waiting. So TURP and TUIP were the very cornerstone options. So TURP was used for everyone, unless the prostate was too big. And at this point, the solution was an open surgery, like a Millen or a Freyer. So the definition of a big prostate, currently now ongoing, was set at this moment. The definition was when TURP was not possible, and it was widely admitted that under 80 grams TURP was okay, and over 80 grams, preferably open prostatectomy would be good, because there was a risk of TURP syndrome and a risk of undertreatment. At this point, and even in the beginning of the 2000s, in our country, in France, we had a nationwide report of all coded surgeries for BPH. And you see that it remains stable, mostly about TURP, because the total procedures that were coded were, for example, like 60,000 in France for a 60 million people country. And we had a vast majority, you see, of TURP against open prostatectomy. It was only like 13%. And if you follow up on what I said before, it means that in your clinical practice and in all over the Western world, only these 15% patients have a prostate of more than 80. So is TURP really the solution for everyone? First, TURP has been challenged because there was, however, some complications. Even in experienced hands, you think that you are the best surgeons, you have the best technique, you cannot avoid complications. And bleeding, as well as ejaculation disorders, were pointed out by the patients and the doctors. It is invasive, and it's not as good as enucleation regarding durability. You see in this graph on the bottom right that TURP at 5 years had like a 5 to 6% rate of reoperation. This is the same study I've shown before, all the codes of surgery in France for every patient. And we looked at the recoded surgeries during follow-up, and we see like 5% at 5 years. On the top right, you have the mean hospital stay duration. And you see that the hospital stay duration, this is the mean and this is the median. The bar is the median. You see that the median was 9 days. It is 20 years ago. It's not 100 years ago. So when you have a mean 9 days hospital stay duration, it means that there are complications. And for TURP, it was close to 5 days. So it means that there are some problems. Indeed, TURP can bring complications. Mortality is estimated to be 1 per 1,000, but you have bleeding, depending on the medication of the patient, depending on the age, depending on the patient presentation. You have the TURP syndrome that bipolar energy can go against. You have some clot retentions, you have post-op AUR, you have infections, and a lot of rarely reported complications, which do exist. So this comes from the systematic review of the literature. In the long term, there are also bladder neck contractors, urethral strictures, some very unusual cases of incontinence, like 2%, and reoperation, as I said before, is estimated to be 5% at 5 years, 10% at 10 years, and 15% at 15 years, very easy to remember. No impact on erection, at least non-comparable to placebo or something like this, but retrograde ejaculation is common, around 50%. So bipolar was introduced to cover the TURP syndrome issue, and hoping that there was less bleeding. So this was the case in comparative studies, but in long-term complications were comparable. So this led the surgeons and the industry to look for the Holy Grail. The Holy Grail would be an alternative surgery that would be perfectly safe and reproducible, suitable for all the prostate size, with an optimal deobstruction, minimal complications, low risk of sexual dysfunction, short length of stay or even day case surgery, and a very low retreatment rate, meeting patient expectations, and at the end, being costly effective. We can minimally agree that if you have all these options, you may have the ideal surgery. So some propositions have been made, and at this point, since TURP was the main surgical option, it was also the main comparator for all alternative options. And in this systematic review of all alternative options, we have seen that TURP was the reference treatment always. It was the case for enucleation that was invented to have a better deobstruction and an increased safety pre-op. Then laser vaporization, which was done to have a non-inferiority deobstruction profile and increased safety regarding bleeding. We had the minimally invasive techniques, we will discuss about this, and aquablation. But everyone was compared to TURP as the reference. So this is probably the most important slide of the webinar. Today, we have a number of options. At the beginning, we had only TURP and open simple prostatectomy. Now see all the other options that have been proposed. You have the green, deep green, that are validated strong 4 option in the guidelines. Light green is a weak 4. And the blue ones are with limited evidence and no recommendation available. You see that some options have been simply replicating the resection. Some have been replicating the enucleation that was done by the finger. Now it's done by bipolar, by the lasers. And vaporization was a new technique derived from the use of laser. We have decided in the guidelines to group them by family, because whatever you use for the resection, whatever you use for the vaporization, whatever you use for the enucleation, whatever the tool you use, you do roughly the same operation itself on the prostate. The alternatives on the right are different. They are not based on resection, vapo, or enucleation. Aquablation is a mix. Robotic simple prostatectomy is a bit an outlier, but non-ablative options like iTind, Resume, Urolift, and PAE are strictly different concepts. There are also a number of emerging options, stents, cages, or more. You will see a lot of them, but they are not ready for clinical practice. So this was the first challenge. I mean, do the obstruction better with new tools to challenge TURPs. The second challenge was operate the right patients. The right patients, because I said at the beginning that age and having money were the 2 main reasons for getting a TURP. It doesn't make sense. So the first breakout was done by Klaus Röhrborn in 2006, where he introduced the fact that BPE enlargement is different from BPO obstruction, which is different from LUTS having symptoms, and also different from histologic BPH. When you consider all men over 40, the vast majority have histologic BPH, but only a number of them have a big prostate and only a number of them are truly obstructed, and only a number of them are symptomatic. And there is no strict correspondence. You can have a big prostate, but no symptoms, and you can have an obstruction, but with a small prostate and big symptoms, and so on. Second thing is that on the right, you will see that if you take all the field of male LUTs, storage, and voidings, a number of other etiologies can be behind. And if you operate a prostate of a guy who is neurogenic, or of a guy who has another problem like underactive bladder or nocturnal polyuria, you will never solve the problem. Indeed, voiding lust have multiple causes. Even if we talk about voiding symptoms, it can be an obstruction by the prostate, but it can also be an underactive detrusor, it can be a dyssynergia, it can be a bladder stricture, it can be many other things. So we have opened our eyes that there are other reasons than obstruction to have voiding symptoms. And it's really important to get the information to operate the right patient. It's even worse when you consider nocturia. Nocturia is mainly linked to other problems than the prostate, except when you have also symptoms during the day. If you have only symptoms during the night, it's highly suspicious of having another etiology like neurological or sleep apnea or endocrine disorders or cardiovascular disorders. And that would be, again, not ideal candidates for TURP. So it has evolved. And now today, we think that male LUTs are the prostate, of course, but also many other things. It was not the case at the beginning. At the beginning, 23 years ago, our EAU guidelines were guidelines about BPH. Now it's guidelines about male LUTs, and he has changed everything, taking into account all the concepts I have explained in the previous slides. There is an interactive app where you can look for all this information about the guidelines. And the last point is the patient choice. We can agree that 30 years ago, patients were taken to the OR by the doctor. Now they don't want to be taken to the OR, and they want to ask you what they want. And their goals are not exactly the same goals as the surgeons. A lot of people, when you ask them in this systematic review about what they want, they prefer less risky options, but avoid the risk and avoid the sexual side effects of surgery. So there is probably a good opportunity to propose less invasive treatment, and this is for the minimally invasives. So if we consider all of this, we have like a personalized treatment, taking into account all the clinical pictures and the patient expectations, completely different from the first diagram I have shown to you before. Now it's completely abundant, and we look at our patients. So we had like two different worlds that challenged TURP. The first was lasers, and the other were minimally invasive. So let's talk about lasers first.
Thank you. You can have a short break if you want, Jean-Nicolas, while we put the first poll before we move on into the lasers and the minimally invasive techniques.
Sure. So let's have this poll. And please tell us what is the BPH surgical options available at your institution. We are aware that presenting all these options, as I did in the diagram, it is what is available, but nobody among us has access to everything. So please fill in this poll and fill also the second question about the choosing the surgical techniques. So I cannot vote, so I count on you very much. For the second question, which factor is the most important when you choose your surgical technique? Among patient preference, your availability, your experience, the cost, prostate size, or our guidelines, which would be a good answer. And third one would be which technique is the most durable, according to what you think. It's a kind of pre-test, because I hope you will learn a lot of things tonight during the rest of the presentation. The last ones are very specifically focused on the HOLEP first. Would you adopt it? I mean, before listening to me. And probably we could ask these questions after the webinar. The other one is training a TORP should be mandatory for every urologist, yes or no, meaning you think that it is still bankable or it will disappear, so it's not bankable to learn it anyway. And the last one are your exposure to ejaculation sparing technique. Do you feel that this is something going up? And this is a very timely question up to now. So, Joseph, I let you take control and close the poll when everybody...
Yeah, I'm waiting for 40 more answers, and then we'll close the poll in maximum 1 or 2 minutes. I'm still getting a few answers. Thirty more seconds. If you haven't voted, please do it. Okay, that's it. Thank you for your answers. And let's go back to the presentation.
That's great. Thank you so much. So if we just stick to the landscape, before the laser came, there were only TURP, bipolar or monopolar, as I said before, and enucleation with your finger. And mainly the energy was mechanic or electrocautery. When the laser came, we had a number of new options and a number of new acronyms. Vaporization was introduced with the photovaporization of the prostate with green light, and the enucleation, endoscopic enucleation, mainly with the HOLEP, were introduced. So this world of lasers has mixed two concepts. The first is the class effects. When you resect, you resect. When you vaporize, you vaporize. When you enucleate, you enucleate. But you mix that with some specific energy-specific effects, because, say, enucleating with bipolar is different from a holmium, which is different from the finger. So it is very important to consider that this is a type of technique and a tool associated together. So tonight we'll discuss extensively about the PVP vaporization with the green light and HOLEP, because these are the two most recommended. So if we talk about the laser properties, what does laser has brought? It's a new way to deliver energy to the tissue. The energy of the laser is absorbed by the tissue according to wavelength, which is the most important. It's favor hemostasis, and it comes to less bleeding complication. You can see here that the visible spectrum is within this wavelength here, and the green light is green because its wavelength is on the green spectrum, and holmium has a wavelength that is a bit more, so it's not visible, but the absorption is a bit different. It's absorbed by water, while the green light is absorbed by the hemoglobin itself. It's absorbed by the constitution of the red blood cells, and it explains why it does bleed so less. When you talk about these lasers, you have the wavelengths, but you have also some mode of operation. It could be continuous, pulsed, or quasi-continuous. Let's get rid of these technical details, which are not important. What is very important when you use a laser is that you must understand there are two different types. Some are front-firing fibers with the energy coming at the end of the tip, and some side-fibering lasers when the energy comes laterally, like in the green light. According to the wavelengths, there is also a very important parameter, except the absorption, is the penetration of the energy. It's very important to consider that the energy has to be minimally deep, otherwise it could go some damages to the tissues and very complicating healing processes, and that's the case for diode and Nd:YAG. So it explains why holmium, thulium, and green light are the most used energies today. So if we focus on the green light PVP, as I said, it's a quasi-continuous laser with a wavelength that is green, and the penetration as a mean value is minimal. You have three different settings: 80, 120, and 180, which is the most used today for vaporization. It can vaporize, but it can also coagulate when you modify your settings. So the surgical technique is very typical. It's under saline, of course, and you have a pump, and you have an optic filter on your camera head. You must wear protection glasses, and this is under spinal or general anesthesia. When you do your surgery, you will create a channel with the effect of a laser, which is a side fibering laser. And as you can see here, the vaporization of the tissue is conducted with a sweeping movement of the laser fibers. I mean, when you alternatively, you go like this, and you will have your tissue burns completely disappearing. The working distance is determined as around 2 millimeters. You don't have to touch it. You have to take some distance to get the max efficacy of this cone of energy here. So when you look at the clinical results of PVP, this meta-analysis I conducted a few years ago has shown that the intervention duration was a bit longer, but the transfusion rate was really lower. And this was the main asset. The catheterization duration, the length of hospital stay, and the bleeding complications were less. And compared to TURP, you have also no differences in other complications, and it appeared to be safer for high-risk patients. The most important is that it was proven as non-inferior to TURP, but doing better in terms of bleeding complications. So the summary of evidence is very clear from the guidelines. It states that it should be offered to men with a prostate volume that is from 30 to 80. Otherwise, like TURP, you may do under treatment because you don't do all the prostate. I know some surgeons do bigger prostates, but it's not in line with the randomized clinical trials we got. If we talk about HOLEP, the concept is a bit different, of course. You have two different steps, the enucleation and the morcellation, as you may know. So you need a laser. You need a lot of material that can be very fragile, and it must be manipulated with caution. And you have your morcellator. And the installation is always the same. You must have an HD camera to do it. Otherwise, you will not see correctly what you do. So the principle of the surgery here is completely different. It's not vaporizing the tissue, it's enucleating. Enucleating means you separate the adenoma from the capsule like you do for a fruit, like leaving the skin of the fruit and getting all the center out. So you push this, you have a mix of mechanical energy and some lasing energy. And one is detached completely, it goes within the bladder. So usually people use like 2 lobes or 3 lobes techniques. And at the end, when it's in the bladder, you have the morcellation, which is used by this very specific type, which rotates with a blade, and it takes with aspiration all the tissue in. When you look at the clinical results of HOLEP, we have here again less bleeding and transfusion compared to TURP, shorter hospital stay and catheter duration, exactly as for the green light, no TURP syndrome because it's saline, of course, and a better efficacy than TURP, similar to open prostatectomy. So that makes the difference. That makes really the difference. But since you remove all the prostatic tissue, or nearly all the prostatic tissue, you have enucleation in the vast majority of cases. You can have incontinence, and there is a kind of a steep learning curve. So if you look at the 1 year efficacy, which is the most interesting, you see that from IPSS and Qmax, it does better than TURP, because when you do a TURP, unless you go to the capsule, you do not do as good as the HOLEP does. And long-term efficacy is also better in terms of Qmax after HOLEP. Why? I said you resect more tissue, and this is proven by this meta-analysis again. When you look at the prostate volume change, after a HOLEP, it's 60% less if you measure ultrasound before and after. It's the same for open prostatectomy. It's not me, it's the literature. But when you look at TURP or green light, you have like a 44 or 45% change. It means you remove more tissue. And again, if you look at these figures, you will see that after an open prostatectomy, or let's say after enucleation, you have minimal redo cases, but that's the case after TURP. But HOLEP has complications, as you can see here, even in very experienced hands. It comes from San Raffaele Milano, from surgeons who have like more than 2,000 HOLEPs in their hands. And they have capsule perforations. They have some bladder damage. They have some acute urinary retention. Okay, it is something that is kind of invasive. It is highly efficient, but it leads to some complications. What we know about the most important complications in the medium term is incontinence. Incontinence occurs in some patients, but it's roughly comes to normal after 1 year, except in some cases. But all patients report ejaculation disorders. If you look at the categories of patients who are at more risky of complications, if you talk about ejaculation, incontinence, and post-op bleeding and reabsorption, a higher age, higher ASA score, higher interculation, higher prostate volume, higher intervention duration, this is increasing the risks. So again, there is no magic trick. It's probably an excellent option to do endoscopic enucleation of the prostate, but there are some complications. So the recommendation is that it is a very, very strong option and validated by the guidelines. When we talk about enucleation, you have some variants. Some other lasers exist, like thulium. We have less evidence for thulium, so it explains why the recommendation is only weak and not strong. You have the diode, which has been described, but with some issues with the healing of the tissue, so it's again a weak recommendation. And it can be done by bipolar, which use a very specific loop for the bipolar, copied here. And you try to do exactly the same thing as HOLEP. And if you succeed to do it, you got, obviously, kind of the same results. Another variant is mixing the green light and the HOLEP. So the green lab, it's been proven as feasible and safe. It's different, using a different tool, but doing the same procedures. There are a lot of tips and tricks to do it. There are no RCT at the moment, so it's not strictly recommended from the guidelines. Finally, if you enucleate, whatever you use, you enucleate. That's why Thomas Herman, my friend from Switzerland, has tweeted a year ago, enucleation is enucleation, is enucleation, is enucleation, and introduced the concept of EEP, endoscopic enucleation of the prostate. Whatever the tool you use, you will get the same results. But the HOLEP has the most important available evidence. That's why I think following the leader is probably the best option. So if we took it back on the Holy Grail, you see that with all our requirements, probably that if you look for long-term efficacy, the HOLEP is probably the best. We can discuss that for hours, but having all these options, you can do more and more targeted treatment. So if we now look at the other side of the spectrum before we have a discussion together, if we look at the minimally invasive options, an issue is standing the test of time. Are these options good for more than just doing a small thing to preserve ejaculation? Is it more than watchful waiting? It is a really bankable treatment. So what we will discuss here, you understood now, is on the right side. It's the non-ablatives. The non-ablatives. The Urolift, the Resume, ITIN, PAE, and not certainly the emerging options because they are not available. So I had the occasion, in collaboration with other statisticians from Boston Scientific, about a year ago, to do a meta-analysis, a network meta-analysis among all these myths. And we came with very nice results in the short term because there are no long-term publications about this. When you look at the comparison of IPSS and Qmax in the short term, if the comparator is TURP, you see that ITINs is not doing as TURP is doing. Same for sham, of course, because if you do nothing, you don't have the same result as TURP. But if you look TUMT or PAE and water vapor therapy, which is Resume, it can be something comparable to TURP. It is short term, remember. If you look at the Qmax, which is about deobstruction, no option except water vapor therapy is comparable to TURP. We know that we do less deobstruction. We have less adverse events, but we have less deobstruction. Of course, when you look at the ejaculation, the MHHQ scores, and the erection, you have better results than with TURP, of course. So let's have a look specifically on these four options. When you look at Urolift, if you are interested to the test of time, we have some data. It's highly recommended because we have a lot of RCTs. Some have been short term when we have these very nice results and information on immediate adverse events. But we have also some long-term studies that have shown that the retreatment rate over 5 years is about 13%. So it's roughly 6% per year in a very recent systematic review. Half of the people got an ablative, like TURP or laser, meaning that Urolift was not enough. Some people got repeat Urolift, and some people have device explant. So it is important to see that it can be an immediate answer to the patient, but there are some risks of being reoperated. If we look at the Resume, we don't have a lot of data against TURP. There was only one study that has shown that the results were quite nice, but of course we can have some retreatment with Resume. It's ongoing. We have a very big study against medications, an RCT coming, and more information is needed to get some recommendations against the reference treatment for Resume, but there is a lot of hope here. If we look at the prostatic arteries embolization, we have data up to 2 then 5 years with an RCT compared to TURP, and these results have shown that we cannot say that PAE is non-inferior to TURP. It's not non-inferior. It is inferior, so we see that we have like close to 20% at 2 years of people who had a PAE who required the TURP, and then at 5 years, it's 50% of people who got a PAE who needed a TURP. So it means that it's close to watchful waiting, but it's anyway having an effect. So what we propose as a guideline is to have proposed PAE in patients who accept less optimal outcomes compared to TURP, and perform only this PAE where in units where the follow-up would be available and where the workup would be adequate. The others are not yet validated on the short term. I can show you all these different devices, which are all made of nitinol. This is the near future. All these implants are self-expanding in the prostatic urethra. This is why they are called like PURE, P-U-R-E, like prostatic urethral expansion devices, but they are not mature. One is the Urolume, it's the balloon delivering some drugs in the prostate, some promising pilot studies, but nothing reliable at the moment. So if we want to discuss that, I propose to kind of conclude that talk. I personally think that this talk cannot be concluded because it's a kind of endless discussion possible, but I would propose you only this slide. This slide seems very important to me because this is indeed what I think and what my guideline group is thinking. Today, we will have a lot of new options. I have shown you all these options in the table with the green and everything. But the most important is that how do we choose and how do we adapt to our patients? Now we have three worlds. We have the world of ablatives, we have the world of minimally invasive, and we have the worlds of behavioral or medicals. There have been a lot of innovations in the medical with the combination therapies, with the PDE5 inhibitors, and even behavioral therapies, like in the last EAU Congress, showing that if you do a bladder diary, if you take your health, and if you follow an app with physical activity, with appropriate diet, you can gain some IPSS, but certainly not from the long term. But it is an open door. The others, on the other side of the spectrum, you have the ablatives with TURP, which is heavily challenged with aquablation, enucleation, robotics, and PVP vaporization. We don't know who is the best here in this box. I don't know. Probably EEP is the most efficient, but it's also the most aggressive. Probably aquablation is a bit less efficient, but it's a bit less aggressive. You know, all these boxes can change in order with the RCTs we will get in the near future. And our future is here. Minimally invasives. So that's kind of a multi-step approach. We can anticipate that the patients who, as I said at the beginning, do not want to get some adverse events, do not want to get sequelae, they will ask for something less and less and less invasive in the future and accept this if they only fail these conservative measures and accept this only if they fail this minimally invasive, except in some very specific cases of complications or retentions, of course. But I think this is shaping the future and a very good basis for discussion together, my friends.
Thank you, Jean-Nicolas. This is indeed a great presentation. I'll ask gradually the questions that are in the chat currently. I want to personally ask a question about resin. In one of the slides, you said that it's a non-ablative technique, and this is how it was described even in your famous paper. So how do you explain that, knowing that at the same time there is some tissue that is removed and some tissue that is becoming necrotic? And
very, very good point, Joseph. I mean, the resume is a non-ablative as you do not get tissue retrieved from the patient. But the injection of vapor you do is leading to the death of a number of cells and is leading to a remodeling of the prostate that is shrinking completely. So it explains that it's kind of magic, but it explains that when you do a ultrasound after a resume, some months after a resume, you may have a prostate reduction in volume, but you didn't retrieve any prostatic cells from the patient. So it's a process of apoptosis and prostate remodeling. For sure, if we do a prostatectomy on those patients, the tissue will be different. It will not be adenoma. It will be like a scar or something like this. The prostatic tissue is changing. But at the same time, it is respecting the anatomic structure of the prostate, which protects against the anejaculation effect.
Thank you. One of the questions is maybe related to prostate cancer. I don't know if this is the topic for today, but PSA versus DRE. What is the place of PSA testing in taking decision for prostatectomy? I mean, we can even extrapolate and ask about when you're managing BPH. Do you really?
Yeah, but it's a very important question, Joseph, because these patients are not prostates. You know, this is something that is I'm deeply convinced of as the chairman of the guidelines. Well, I mean, today I'm Jean-Nicolas. I'm not the chairman of the guidelines. But what I think is that these patients are patients. They are not prostates. So, of course, they will ask about prostate cancer. And doctor, what is my risk? How are you sure that there is not a cancer leading to my symptoms? So this is a very nice question. And if we look only at PSA and DRE, I would say that both have their lack of sensitivity. Because when you do PSA, we know that we have like lower PSAs, you can have prostate cancer. And when the higher PSA, you can have no prostate cancer. But I think that PSA is coming over DRE. Because DRE is only exploring the posterior face of the prostate. It's missing like anterior lesions. Mm-hmm. So that's the first thing. Second thing is that patients are less and less keen to get a DRE, at least in Europe and in the United States, because they have learned that PSA is also important, and they prefer just having a PSA. And there was a paper published recently by Peter Alberts from Düsseldorf, who is a kind of a pope of prostate cancer. And in this study, they compared patients who had both PSA, DRE, and the conclusion is that DRE is useless because they got all the prostate cancers diagnosed via the PSA dosage. So probably it is moving on this way to the field. But since my screen is still on, I would like to get back just on this slide, which is about the Holy Grail. You can see that with ablatives, there is something to say about OLEP and PVP, Joseph. When you look at the OLEP, you remove all the adenoma and you also get the pathology examination. When you do a vaporization, which would be good for a man who just need like not a big invasive enucleation, but just a channel or just improving obstruction. When you do PVP, there is no pathology material because the cells are really exploding completely. The tissue is vaporized and you do not get this information. Mm-hmm. So if we link to the question of prostate cancer to our topic today, if you have a doubt, you have to go to the MRI first. Mm-hmm. So you can do your DRE, but PSA is probably more important. I say probably more important. If you have a doubt, you may go to the MRI before the biopsies. And if you have a doubt about the presence of prostate cancer on a guy you are operating, please choose an ablative technique like TURP or HOLEP to get some pathology material to be sure that there was only adenoma.
Thank you. Thank you. One more question. What are the factors to decide on which technique to perform, retropubic approach or transvesical approach for open prostatectomy? That's a debate, always a debate.
Yeah, always a debate. I mean, you're talking about benign, right?
Yeah, for benign.
Yeah, for benign, if you do like a robotic approach, I would say transvesical is kind of more bleedy. And I personally prefer to have something anterior. Mm-hmm. But again, this is a nice question, but we need objective comparisons. We will need like a randomized control trial that is not available today. It sounds like, a standard answer. When somebody wants to know the word of the expert, when the expert is saying, well, we don't know, we need an RCT, it could be seen as a very conventional answer. But this is true, Joseph. We talk only about experts and we talk only about things we are doing. Every surgeon, as we are, does what he is good at. And if you want to get out of your comfort zone and if you want to try something else, at the beginning, you will have a very subjective evaluation of the process. And even when an expert is talking to you, for example, saying, I'm doing green lab, I'm the king of green lab, come to my hospital and you will learn green lab and it will be fantastic. It's only a one-person opinion. So more than ever, if we have like very interesting questions like this, you would consider comparing the same patients within an RCT, for example, and having some reliable surgeons in each arm comparing this. It is possible, Joseph, that this kind of study doesn't show any difference. And it goes to the answer, do what you are good at. and do what you have been correctly taught.
Yeah. Thank you. The indications for surgery, question from Mr. Olivier Elius. Indications for surgery for BPH, and do you still do the wait and watch? The biopsy reveal a Gleason score in accordance with BPH. Do the wait and watch the biopsy? There is, I think, a word that is missing. If there is a low Gleason score, do you still do the wait and watch, the active surveillance?
It's about the topic, Joseph, of discovering prostate cancer on a BPH surgery. It happens sometimes, of course, and if you find like a ISUP2, ISUP3, or high Gleason score, you would be facing a threatening prostate cancer, and you will go for an additional therapy, for example, considering radiation. But if you find like a Gleason 6, ISUP1 prostate cancer in a small amount of your pathologic tissue, I think you would stay with watchful waiting. It's very important to understand this. We can do MRIs. We can do surveillance and even MRIs on operated prostates. And I would say another message that is very important is that even when it is benign, you have to continue to follow your patients. If you've got a HOLEP, you continue to have a PSA every year or every 2 years, because prostate cancer can always occur, because there is no zero prostatic tissue after these benign procedures.
Okay. Thank you. A question from Mr. Anastasios. Which technique would you suggest for an older patient above 80s with a retention to obtain a successful catheter removal?
It's a very important point.
I mean, we are PAE. The question is, would you go for a PAE?
I will discuss that. We have always in mind, when we look at all these guidelines and everything, a very standard patient like you and me, saying the 60 years old, 60 grams without any problem, you can choose everything. But if you are in reality, like having an 85 years old with a nursing home guy, struggling with a permanent catheter, it is another issue. First question is, does this guy have a chance to pee again? It can be strange as a question, but if the retention is really, really chronic and like was there for decades, maybe you could operate the prostate and nothing will happen anyway. So there is a risk in this very old patient that they do not pee anyway, even if you do a nice surgery. So the question would be, if you do a surgery on this person, would you take the maximum chances to de-obstruct him and do like a HOLEP, for example? It's probably not a very nice choice, because the durability is not the question. The patient is already very old and will die from another reason probably. And there is a very high risk of incontinence on these patients. When you do a HOLEP on a big prostate or a very, very old guy, you have like 10 to 15% chances of having some incontinence, and you would never go back for an operation or a sphincter or something like this. So the patient has to be warned that there could be a failure of the surgery first, and second, that the more invasive you are, the more risky you are in your approach. So like in between, like a photovaporization of the prostate, for example, which is never bleeding and you can stop just to have a channel to get the patient peeing again, or a PAE to see what's happening, is probably an option. I would prefer like creating a channel with a mini invasive, like photovaporization of the prostate, green light in this guy, for example, because we will anyway create a channel and see if the bladder is competent to pee again. And PAE, there are some studies, but these studies are not very strong, and they're only case series. There have never been like comparative studies against ablative options. And remember that PAE is also about necrosis of the prostate tissue and ischemia of the prostate tissue. So it will take a lot of time. I don't know if this guy would benefit immediately or shortly from this PAE if there is a catheter in place. The last point I would stress out is one paper that has explored the eye tint. You see this small nitinol basket expanding on the bladder neck. It would be a nice test, like a urethral prosthesis for this guy, putting an eye tint since he is in retention. If he pees correctly after this eye tint, I mean, you did nothing. It's not risky at all. Well, obviously, it could fail. Huh? But there have been some small studies suggesting that in these very sick patients, you may prefer really minimally invasive ones. I'm not aware of a specific resume trial in these very, very poor patients, but it could be also an available option.
Yeah, there is, I think, one retrospective study done in France about this.
It was on retention. It was on retention, patient with retention. It was not focused on elderly, but it was a patient retention. And absolutely, you're absolutely right, Joseph. I can't remember the figures exactly, but they have a significant number of patients with a permanent catheter treated with Resume and peeing again after this procedure.
Yeah, I agree. Thank you. Retrograde ejaculation, is there a way to treat it, and is it very common after stroke?
Yeah, TURP is leading to like 50 to 60% of retrograde ejaculation. The question is, sir, is that a retrograde or is that an anejaculation? Yeah, it's always the debate. I mean, we learned a lot from the field of enucleation. We have seen that when we remove everything, there is no ejaculation anymore. When we do an enucleation, most of the times, if we remove all the prostatic tissue, nothing comes out. If you want to preserve ejaculation with your ablative surgery, it is possible. The main important target is the verumontanum. Around the verumontanum, you have the channel, the ducts coming there from ejaculation. If you want to increase your chances to keep ejaculation after surgery, you may prevent this by not ablating the tissue that is 1 centimeter above the verumontanum. If you spare the apex and do kind of a selective surgery, you can keep ejaculation with 70% chances. It's been proven in nice papers with a selective green light photovaporization. When you do the green light vaporization of all the fossa, with everything, but you stop at the end, not going to the veru, and even some partial HoLEP or only removing the median lobe can be an option.
Okay, thank you. A question from Mr. Inmar Habib, who is actually a HoLEP expert that I have been watching today. Thanks for the nice presentation. How do you see Resume in the era of prostate enucleation? As a HoLEP surgeon, it's very difficult to see the post-Resume result for the patient. And when I tell the patient we need to undergo HoLEP after Resume. So
yeah, this is the heart of the business. Thank you very much. I mean, this is the last slide I've shown to you. And I'm switching on this. I think it will happen, but it will be patient driven, because when you have a patient facing you, if he needs a HoLEP, you know it. I mean, the guy has a very poor flow. He's really obstructed. He has post-void residual. The ablative surgery, no doubt, will be great for this guy unless he doesn't want it, and we can try a Resume. The question is, if your patient has a small residual, he's not happy with the medications, and he has a flow of 13 or something like this, would you go for a HoLEP or TURP? Probably not. So for all these intermediate patients, I think that minimally invasive treatments are a good option. And even for some patients with bigger problems, if they want to try it, you can do it. But There will always be failures, of course. If you have a very big prostate, notably, resume is not probably adequate for those patients. It's recommended for patients with 30 to 80 grams prostate. And if you have a very high PVR, for example, deobstruction may be mandatory. Remember that when you are doing an invasive surgery, you have the maximum deobstruction efficacy. It is what is written on this slide. If you need a maximum deobstruction efficacy because you want the patient to be relieved from this for the rest of his life, probably EEP, endoscopic enucleation of the prostate, is the best. If you have a doubt about enucleation, about obstruction, like with a Qmax of 13, if you have a doubt about the fact that there is really an obstruction, or if the patient doesn't want adverse events, you must consider, I think, these ones. Today, in the world of enucleation has a very important place, but you cannot blind the patients from this box.
Thank you. Again, more questions. A few more. We will take maybe 4 more questions quickly to be conscious of time. Now the geriatric group is increasing, therefore we need to come with a minimally invasive techniques, less complications. Yeah, this is the same spirit of minimally invasive could be a solution for patients with multiple comorbidities. I think that has been discussed before.
This is what we propose in the guidelines. Multiple comorbidities are, as I said before, the patients who will get the complication from HoLEP. Remember the slide with the predisposition to complications. It goes very high if you have an ASA3 patients or anticoagulation therapy or very frail patients with a high comorbidity rate. You would never want this guy to bleed. You would never want this guy to stay in the hospital for long. So minimally invasives, even in local anesthesia, are something that should be considered. And they are multiple candidates that we would drive to these solutions. Embolization itself, it's been considered as the beginning a solution, and we discussed that in a previous question. It has been presented as a solution that is harmless for these fragile patients.
Okay, thank you. A question about, again, ejaculation disorders. We have discussed it briefly, like the difference between anejaculation and retrograde ejaculation. Is this really clear now and well established? Like, is it really anejaculation more than retrograde, right?
Yeah, I mean, when you do enucleation, it's really more anejaculation because it's a problem of production of sperm by the prostatic tissue. What is sure is that you cannot get it back. I mean, once there is an ejaculation disorder, it's very complicated to get it back. So it's an irreversible complication. It's considered like this. If it is retrograde, you can analyze this within the urine, a post-coital urine test. You can see like some sperm in urine. It's mostly because you kept some prostate alive, like you did a TURP, but halfway, like you took 50% of the prostatic tissue. But there is like a dysfunction of the musculus ejaculatorius, which is the main driver of ejaculation. So we have worked on this a lot, and this is why we have considered sparing the perimontanal tissue, as I said before. This is where the ducts, ejaculatory ducts, are coming, and this is where the musculus ejaculatorius is closing the urethra during ballistic ejaculation by having like the vermuntenum like coming there, like closing the urethra and having all the sperms after this.
Okay, thank you so much. No more questions, please. I feel like we're getting, I really appreciate the feedback as well, very positive feedback. What do you think about single lobe only TURP for big prostates? Oh,
Well, the question is about how you get TURP in big prostates, right?
maybe, yeah. It may be stage. I think it's more about stage TURP for big prostates. I heard about it before.
Yes, big prostates, it's a challenge because you do not want to undertreat, right? You want to have a nice result after surgery. You don't want a patient to recur. So what we know about resection and vaporization is that there is in these big prostates a risk of recurrence of obstruction. So the gold standard today is considered as enucleation, really. So to avoid undertreatment, you would prefer enucleation today or aquablation. I've seen some studies about this. Some comparison are ongoing between HOLEP and aquablation also. So we will have some informations. But you know, when bipolar came, we say, well, there is no TURP syndrome, Joseph, so we can go to up to like 200 or something because we can do resection like for 4 hours. But you know that it doesn't work. It bleeds. Anyway, you are suboptimal. This is not a good solution. Provided enucleation exists, I think that for very big prostate, you should go for it. And probably the bar of 80 is a bit strict. You can go to 100. Let's say that if you have some nice expertise, but that's really a minimal margin.
Okay, thank you. What's your opinion on TUIP for men, especially in developing countries where minimally invasive surgeries are not available?
TURP remains the cornerstone.
Sorry, the incision. TUIP.
Well, TUIP is nice. TUIP is nice, but it depends on the shape of the prostate. I have published a paper that is, I think, available online with a video that is easy to access. It is avoiding cystoscopy. When we try to do some cystoscopies in patients who were voiding, and we have different profiles. The first one was having these lobes that are completely opening during voiding in a normal patient. The other profile was having these lobes staying like this and do not open when you have the voiding. And we have some patients with opening of the lateral lobes, but a big median lobe coming in the middle. So it depends on these patients who have a big median lobe or who have a posterior wall that is with very contracted bladder neck, you can do it. But if there are some big prostatic lobes, and if they are not opening and if they are responsible for the obstruction, I think TUIP would not be a good solution.
Okay, thank you. What else? Last question. Approach of lots due to BPE and setting of Parkinsonism, especially risk of incontinence post-surgery. You're not really in the topic, but if you want to answer before we close, it would be good.
Yeah, question is about the persisting bloods after surgery, right?
The Parkinsonism for patients with
Parkinson, sorry. Parkinson, yeah, it's an excellent topic. So we should start a new webinar right now, but because this is an entire world. Very clear messages for this, Joseph. For Parkinson disease, first thing is that you have Parkinson disease and Parkinsonian syndromes. It's not the same. If the patient has real Parkinson disease, there may be some issues. If there is a Parkinsonian syndrome like shy-dragger or dysautonomia, you will never touch those patients because you may have a patient worse after surgery. So if we stick to Parkinson, the key is the obstruction. If there is an obstruction, you may be better with your surgery. If there is no obstruction, you will be worse. So you will never touch the patient. So urodynamics are the key. If at the urodynamics, you find obstruction, Joseph, in a Parkinsonian patient, you may consider surgery, but you will be very careful if there is overactive detrusor. If there is overactive detrusor, you may have worsening of the symptoms afterwards, with especially incontinence. So my counsel would be privilege the drugs, alpha blockers, everything you can. And if you consider surgery, urodynamics are mandatory, and please ask an expert.
Mm-hmm. Okay, thank you, Jean-Nicolas, for this great presentation and for answering all the questions, despite being a bit ahead of time. So again, thank you everyone for joining us, and I hope you enjoyed the session. Also, as I mentioned before, you can log into Educare, find what's next in our educational events. Jean-Nicolas, do you need to say a final word maybe before we close?
Thank you so much, Joseph. I think it's very interesting to have this kind of webinars when we can discuss several aspects. What I would like to stress out is that more than ever, tailored therapy would be the future of BPH. And also, you have to open your views. LUTs are not only the prostate. This is really the message. If you choose the right patient, and if you ask your patient what he wants, probably with your tools, with your expertise, you will get nice results. If you do not operate the right patient, even if you are golden hands and a magic tool to do the surgery, it will fail.
Okay, great. Fully agree. Thank you, everyone. And I hope you have a great evening as well. Bye-bye. See you next time. Thank you.
Thank you, everybody. Goodbye.